Welcome to Pulse and Pressors, where critical care gets crystal clear. In this session, we'll walk the complete CABG journey from pre-operative optimization to day one post-op milestones, so you can anticipate needs and prevent and mitigate complications. Coronary artery bypass grafting reroutes blood flow around obstructive coronary lesions to restore oxygen delivery to jeopardized myocardium. We use a proximal inflow source, either the aorta or an in-situ internal mammary artery, connect a conduit, and anastomose it to the coronary artery beyond the stenosis. CABG improves symptoms and, in specific anatomies, like left main and complex multivessel disease, survival. Pre-op begins with a tight risk inventory, clinical history, ischemic burden, ventricular function, and extracardiac comorbidities. Recent angiography guides our targets. TTE or TEE defines left ventricular function. We score risk with STS or EuroSCORE and counsel patients on benefits versus risks. Medication hygiene matters. Continue aspirin. Time P2Y12 holds to reduce bleeding. If ischemia is ongoing or anatomy is precarious, we bridge with intravenous heparin pre-op. We'll discontinue and manage anticoagulation in the OR. Keep beta blockers on board if tolerated. Start or continue high-intensity statin, and for blood glucose control use, instituted insulin protocol. Consider a balloon pump for severe left main, very low EF, or refractory ischemia. In the OR, we place reliable access and monitoring, arterial line, central line, and often a PA catheter. Anesthesia balances hemodynamics and lung protection, while TEE becomes our intra-op echocardiographic eyes. Cell saver and antifibrinolytics stand by to conserve blood. For on-pump cases, we fully heparinize and go on cardiopulmonary bypass. The pump handles circulation and gas exchange, letting us clamp the aorta and arrest the heart with cold, potassium-rich Cardiplegia. We maintain flows around 2.2 to 2.4 liters per minute per square meter and aim for a MAP near 60 to 80. With the heart paralyzed and protected, we sew distal anastomoses first, then proximals after the clamp comes off. Free grafts, Radial or Saphenous, have their proximal ends sewn to the ascending aorta using a side-biting clamp after cross-clamp removal, and their distal ends to the targets. In contrast, an in-situ internal mammary artery is already supplied from the high-pressure subclavian, so only its distal internal mammary artery to coronary anastomosis is sewn while the heart is arrested. Our drug cabinet includes heparin, Cardioplegia, vasopressors, and inotropes tailored to physiology, antifibrinolytics to limit bleeding, and protamine to reverse heparin at the end. If vasoplegia appears, agents like methylene blue may rescue. Off-pump CABG avoids the pump entirely. On a beating heart, stabilizers create local stillness while we graft. It's valuable for patients where avoiding aortic manipulation or cardiopulmonary bypass is strategic, but it demands an experienced team and vigilant hemodynamic management. On off-pump CABG, you still give IV heparin, but you typically target a lower ACT than on full cardiopulmonary bypass, and subsequently reverse with protamine sulfate at closure. Among conduits, LIMA to LAD exhibits the most favorable long-term patency profile and is routinely prioritized. Additional arterial options include the right internal mammary artery and the radial artery. The radial has the best patency when the target coronary has high-grade stenosis approximately greater than or equal to 70 to 80%, which minimizes competitive native flow and reduces the risk of graft occlusion. Always confirm adequate ulnar collateral flow and guard against spasm. The saphenous vein remains versatile but shows lower long-term patency. In younger patients, arterial grafts, like the internal mammary artery, are strongly preferred due to their superior durability and patency over decades. We prefer arterial grafts when longevity matters, especially for the LAD. We choose veins when reach, number of targets, or patient-specific constraints limit arterial harvest. Age, diabetes, sternal wound risk, spasm tendencies, future dialysis needs, comorbidities, and stenosis severity all influence the plan. At closure, mediastinal drains prevent tamponade, and pleural drains evacuate air and fluid when the pleura is opened. We routinely place epicardial pacing wires, atrial and/or ventricular, for rhythm support and diagnostics. Vigilant monitoring of tube output and patency is critical in the first hours. Coming off pump, we rewarm, optimize electrolytes, correct potassium and acid-base balance, and titrate vasoactives to meet perfusion targets. We reverse heparin with Protamine, audit hemostasis, and correct coagulopathy by labs or viscoelastic testing. Cell-saver blood reduces donor exposure. On ICU arrival, stabilize airway, breathing, and circulation. Track ABGs and lactate trends. Target a MAP of 65 to 80, a cardiac index above 2.2, and a mixed venous saturation above 60 to 65%. Watch the chest tubes frequently. Their output tells you the bleeding story. Notify CT surgery if their output is equal to or exceeds 100 milliliters in an hour, and keep electrolytes in the sweet spots to prevent arrhythmias. On ICU arrival, chest tubes are typically placed to suction, for example, negative 20 centimeters of water, unless a provider orders water seal or otherwise specifies. As the patient rewarms, both systemic vascular resistance and central venous pressure often fall due to vasodilation and redistribution of volume, sometimes unmasking hypovolemia. Anticipate the need for fluid boluses and short-term vasopressors to maintain perfusion targets. When warm, stable, and not bleeding, extubate early, often within 6 hours. Incentive spirometry, splinted cough, and early pulmonary hygiene. Limit atelectasis and pneumonia. Gentle diuresis after stabilization helps clear lung water. By post-op day 1, aim for a chair, then short ambulation. Resume or initiate secondary prevention. Aspirin for almost everyone. High-intensity statin, beta blocker, and ACE inhibitor when appropriate. Amiodarone is used for atrial fibrillation prophylaxis in some cases, provided it is not contraindicated. Gentle diuresis is often initiated as the patient rewarms and mobilizes fluid from the third space. Aim to optimize preload and pulmonary status without compromising perfusion. Consider removing chest tubes when drainage is low. Some institutions define this as less than 100 milliliters in 8 hours, and stable per protocol, and remove pacing wires once coagulation is normalized, the rhythm is reliable, and the patient isn't pacing dependent. For chest tubes, pre-medicate, pull at end expiration or with a coached Valsalva, and seal the site. For pacing wires, confirm an intrinsic rhythm, ensure wires are grounded, and patient is not pacer dependent. Pull supine at end expiration, and monitor closely afterward. Reassess for recurrent effusions, tamponade signs, or rhythm issues. Some protocols require monitoring for 4 to 8 hours before discharge after wires are pulled. Prevent complications by anticipating them. Treat bleeding and tamponade promptly. Manage low output with careful preload, afterload, and inotropy, and escalate to mechanical support if needed. Expect atrial fibrillation and have a clear rate or rhythm strategy. Protect the brain, kidneys, and lungs with meticulous perfusion and early mobilization. After CABG, think tamponade, when shock presents with a narrow pulse pressure, rising neck veins, and falling urine output, especially if chest tube output shows an abrupt drop or complete cessation. On the A-line, look for pulsus paradoxus and a shrinking map. With a PA catheter, cardiac index falls while right and left-sided diastolic pressures crowd together. Diastolic equalization is the invasive hallmark. To elaborate, you will see cardiac index fall and increase in CVP, and right atrial pressure, right ventricular end diastolic pressure, PA diastolic pressure, and wedge pressure converge to within approximately 5 millimeters of mercury. Mixed venous trends down as delivery collapses. Echo confirms the physiology with right-sided chamber collapse and a tense collection. Remember, ventilator pressure can hide pulses, your invasive trends and echo won't. Believe the drain. A sudden cessation of tube drainage plus crashing hemodynamics is tamponade until shown otherwise. Inspect for kinks or clot at the skin site, but don't let troubleshooting delay escalation. Call the surgeon immediately and prepare for re-exploration while you run balanced blood product resuscitation, correct calcium and temperature, and support map with pressors. Use epicardial pacing for bradyarrhythmias and obtain confirmatory echo. In post-sternotomy patients, the culprit is usually clotted, loculated blood. Pericardiocentesis rarely solves it. Definitive therapy is rapid surgical evacuation, followed by reassessment of drains, perfusion, and antithrombotic strategy. Discharge readiness includes a robust secondary prevention plan, structured cardiac rehab, and education on wound care and when to seek help. Early, consistent follow-up and lifestyle interventions convert a successful operation into durable, long-term outcomes. This is Pulse and Pressers, providing a daily education on the marvels of the human body.